Hi, everybody. Welcome once again to our weekly data interpretation crash course. Thank you for joining us for this evening. Today we have Aditi, who is a fifth-year med student from Imperial, who will be giving us a tutorial on how to interpret LFTs and abdominal X-rays. So without further ado, I will pass over to Aditi now, and you can begin the tutorial. Thanks very much.
Thank you, Chang. Hi everyone. So as Chang said, today we're going to try and cover liver function tests and abdominal X-ray interpretation. So I tried to do around maybe 20-30 minutes of talking about how to interpret them, and then there's some questions at the end which are on the handout too, which we can go through together. If you have any questions at any point, please either unmute yourself or put it on the chat and let me know, and I can try and answer the question. And if you want to make notes throughout, then please do, but I think I've made quite detailed notes in the notes bit of the presentation, which you should have access to after. So some of the blood tests which are used to assess liver function are these. Liver function test is a bit of a misnomer because only really albumin and prothrombin time are markers of kind of the synthetic function of the liver to test how it's functioning. The others are markers of, for example, alanine transaminase, ALT, and aspartate transaminase, AST, are markers of hepatocellular injury, and alkaline phosphatase, ALP, and gamma glutamyltransferase, GGT, are markers of cholestasis, which is when you have impaired flow of bile. Bilirubin is another test which can be used, and that's a marker of hemolysis and cholestasis too. We just spoke about albumin and prothrombin time, and there's also alpha fetoprotein, which is a marker of hepatocellular carcinoma and also germ cell tumours. We're not really going to talk much more about that one because there isn't really much more to say. So we're going to focus on the green and the red ones today. There are obviously other investigations which you can do to assess kind of liver function, but these are the ones we'll focus on today. So before we go through it, there's just a disclaimer that it's important to interpret liver function tests as you would with other investigations in the context of the history and also the clinical examination as well. So moving on to liver disease, there's quite a few kind of liver-related conditions you need to know about in third year. I got these from Sophia. And with regards to interpreting liver function tests, it can be quite useful to try and categorize these conditions into different types of liver injury, because they tend to show different blood results. So you can have an acute hepatocellular injury, and that's injury to the liver, which is kind of occurring from days to weeks. So examples of this would be infection, such as hepatitis B infection, liver ischemia, and drug-induced toxicity to the liver as well. So I have a question, if you don't mind unmuting yourself or putting in the chat, what is the most common medicine taken in overdose? Yeah, perfect. So paracetamol, and that affects the liver. You also have causes of chronic hepatocellular injury, and that will be kind of injury lasting months. I've listed some here that are on Sophia. You can also have cholestatic types of liver injury, so things which are impacting on the flow of bile. And finally, you can also have a mixed picture. So some of these conditions you could arguably put into multiple categories. For example, hepatitis B infection can be acute, but it can also be chronic. And a few of the hepatocellular injuries can also impact on the flow of bile as well. So looking more closely at the liver enzymes, I've drawn a diagram, which isn't very pretty, but I hope is quite simplified. So you have ALT and AST, which are found in the hepatocytes in the liver, and these are markers of hepatocellular injury. So when your hepatocytes get damaged and die, these get released and so appear elevated in the blood. ALT is more specific to the liver than AST, and I remembered that by its ALT, so low in other tissues, which obviously it doesn't stand for, but that's what helped me remember. AST has a few extra hepatic sources of enzymes, which I've listed in the blue box. You also have GGT and ALP, which are found in the liver too, but these are markers of impaired bile flow. ALP in particular has quite a few extra hepatic sources. So for example, in the bones, the kidney and the placenta. And so this is why it's really important to interpret liver function tests in the context of the history. So if it's a pregnant woman, for example, and she has a raised ALP, it probably isn't due to liver injury. It could just be due to the fact that she's pregnant. And I've put little martini glasses next to GGT and AST because these are more specific for alcohol consumption. So they tend to get elevated when you've consumed alcohol. So just wanted to talk a little bit about bilirubin as well. Does anyone know where bilirubin comes from? Yeah, perfect. It's the breakdown of red blood cells. And when you have high levels of bilirubin, it's clinically manifested as jaundice. And when you kind of have it, we're taking a history from a patient with jaundice, it's quite important to try and determine where the kind of raised bilirubin is coming from. And in order to do that, it's quite important to understand the cycle of bilirubin. So you have unconjugated bilirubin, which comes from the breakdown of red blood cells. And this is water insoluble, and that's why I've put it in yellow. It travels in the bloodstream bound to albumin. It then goes to the liver, where it's conjugated and glucuronic acid is added to it, and it becomes water soluble, and that's why it's blue. This is important later on. The conjugated bilirubin then is kind of secreted with the bile via the biliary tree into the intestine. It's not absorbed in the small intestine because it's quite a large molecule, and so it travels until it gets to kind of the large intestine area, and there's bacteria which release free bilirubin and reduce it, forming urobilinogen. And then from this point, two things can happen. Urobilinogen can either be further converted by the bacteria into stercobilin, which is a brown pigment and makes your feces brown, and be excreted that way. Or it can kind of go up. Sorry, it's not the best. It's not the best drawing, but there's this kind of starry line is representing the portal vein system. It can kind of go via this way back into the liver, where it can be recycled and kind of go through the biliary tree again. Or it can be absorbed into the bloodstream, where it will then go to the kidneys, and because it's water soluble, will be excreted via the kidneys. I've put these numbers 1, 2, and 3 because these are the points in the cycle where there can be problems and cause accumulation of bilirubin, causing jaundice. So the first one's called prehepatic jaundice, and this is when you have high levels of unconjugated bilirubin, and this can be due to if you have kind of something which is causing increased red cell breakdown. The rest of the bilirubin pathway is working fine. So the unconjugated bilirubin is able to be conjugated. It's just that there's too much of it. So not all of it's being conjugated. And so this results in the jaundice color. However, you are still producing stercobilin and urobilinogen. And so there's no change in the color of feces or urine in prehepatic jaundice. You then have hepatic jaundice, which I found quite confusing. And I think that's because it depends very much so on the disease process itself, depending on what happens. For example, in viral hepatitis, you tend to have high levels of unconjugated bilirubin because viral hepatitis affects the conjugating ability of the liver. Whereas if you have kind of taken antibiotics or something like that causing damage to the liver, that tends to cause high levels of conjugated bilirubin. We've just spoken about the kind of disease process of having high levels of unconjugated bilirubin, so we'll focus on if you have high levels of conjugated bilirubin. It's able to go through via the biliary tree into the intestine, and urobilinogen and stercobilin are being formed. However, because you have quite a lot of conjugated bilirubin, some of this leaks into the blood. And so because it's water soluble, it's able to be excreted by the kidneys. And it's a slightly darker color than urobilinogen. I think it's like a reddy brown. And so urine appears dark in hepatic jaundice, whereas there's no change in color to the feces. And then finally, you have posthepatic jaundice, which is also called surgical or obstructive jaundice. And that's where the flow of the conjugated bilirubin is impaired and it's unable to enter the intestine. As a result of this, you're unable to form stercobilin, and so your stools appear quite pale or like acholic. And because unconjugated bilirubin is unable to enter via the biliary tree, it leaks out into the blood, and again, is excreted by the kidneys, and so causes dark urine. Yeah, sorry. And so this table kind of summarizes what I spoke about quite quickly for you to go over in your own time. I hope that makes sense. In terms of when you're interpreting kind of bilirubin as a liver function test, you don't really request tests looking separately at unconjugated to conjugated bilirubin. You'll tend to just request total bilirubin levels. This is kind of more relevant for if you have a patient that presents with jaundice. It's important for you to ask the color of their urine and the color of their stools as well, because it might help you to narrow down your differentials. So based on what we've just spoken about, I tried to make a flow diagram to put it all together. So if you have someone that comes in with jaundice, you probably kind of request liver function tests, such as looking at the hepatic enzymes. When you request your hepatic enzymes, it's important to first look at your ALT and your ALP. If they're normal and someone has jaundice, it's quite suggestive of a prehepatic cause. And this is because, if you remember the diagram at the beginning, ALT is associated with hepatocellular injury, and ALP level increases are associated with cholestasis. So if they're normal, it suggests that the jaundice is maybe coming from somewhere else. If you have a predominantly high ALT, this suggests that it's a hepatic cause because it's hepatocellular injury. And the next step after that is to look at the AST to ALT ratio. So you want to see the values of AST compared to ALT. If AST is 2 times greater than ALT levels, and you also have a raised GGT, it's very suggestive that the kind of liver function tests are due to, the deranged liver function tests are due to alcoholic liver disease. If you remember in the first slide, there's the martini glasses next to AST and GGT, and that's because they're kind of more sensitive for alcohol consumption. This ratio is not very useful if it's not 2 to 1. It would just be suggestive of other causes of liver cell injury. If you have a predominantly raised ALP, that would suggest a post-hepatic cause of jaundice. And then you'd look at your GGT levels. If that's also raised, it would suggest a cholestatic cause. However, if the GGT is normal, and perhaps if this patient didn't have jaundice and you had an isolated rise in ALP, it would maybe be suggestive of an extrahepatic cause of jaundice. If you remember that ALP is found in the bones and also in the placenta. And so it could be due to kind of those other disease processes causing the raised ALP. I try to use jaundice as the starting point here, but you can kind of use the same layout in terms of first looking at ALT and ALP, and then working your way down the tree, even if the patient isn't really presenting with jaundice. I hope that makes sense. Let me know if there's any questions on how to go about interpreting the hepatic enzymes. In the meantime, we'll move on to albumin. So albumin is a protein, and it has a key role in maintaining the oncotic pressure of the blood. And so when it's low in levels, it can cause ascites, which is seen in kind of decompensated liver disease. So some of the reasons for decrease in albumin can, number one, be to decrease production. So in chronic liver disease, as the liver is responsible for synthesizing albumin, if it's not functioning very well, you're going to have low levels. Albumin is a good marker of chronic liver function as a result of this. It's not the best marker for acute liver function, and that's because albumin has a half-life of 20 to 30 days. So a better marker of acute liver function is prothrombin time, because that's kind of measuring the synthesis of the clotting factors made by the liver, or INR, which is derived from the prothrombin time. Malnutrition is also another example of decreased production. You can also have an excessive loss of albumin causing a decrease, and that would be the nephrotic syndromes that you need to know about in renal medicine. And you can also have a decrease in albumin in cases of inflammation. So you have positive acute phase proteins such as CRP and lactate, which tend to increase when you have inflammation. In the same way, you have negative acute phase proteins. So these proteins decrease when you have inflammation. Albumin's one of them. Obviously, it's not the best test for kind of when you suspect inflammation, because inflammation can be caused by a variety of things, such as a UTI, as well as a myocardial infarction. So I made this table at the end just to kind of summarize when you have different conditions, which tests would be important to have a look at. Obviously, they are all important, but the ones which might be deranged kind of to the greater extent. And that's liver function tests. Does anyone have any questions about that before we move on to abdominal x-rays? Okay, if you do, we can go through it at the end. I'll just move on. So abdominal x-rays can be used when you suspect bowel obstruction, if you're kind of looking for stones, you suspect bowel perforation, and to check the lines, tubes and line positioning. It can also be done if you're expecting like foreign bodies, for example. And you tend to do abdominal x-rays when the patient's lying down, the supine position. However, you can also do it when they're stood up. And the advantage of that is that if you're kind of expecting fluid levels, you can kind of see those a bit clearly. So when you're interpreting abdominal x-rays, I found this quite difficult because I feel like for chest x-rays, you're given quite a rigid, ripe A, B, C, D approach. Whereas for the abdominal x-ray, it seems a little bit more vague to me. I use this mnemonic, but there are other ones. I think Geeky Medics uses BBC for bones, bowel, and calcifications. But this one stands for A for air, B for bowel position, size, and wall thickness, D for dense structures, so such like calcifications and bones, O for organs and soft tissues, and X for external objects and artifacts. And so whenever I see an abdominal x-ray, I try and work through this schema just to see if there's any abnormalities and where they may be. So the first thing, this is a normal abdominal x-ray, but you'd first of all look for the presence of air. It's normal to have air inside the bowel. And just to recap, as I always get confused, air in an x-ray appears darker, so like black, whereas solid structures appear white. And so it's normal to have air in the bowel. It's when it's not in the bowel, which is when it's a bit worrying. This is a normal x-ray, so the air is fine. Next, you'd look at B, which stands for bowel, and you'd want to differentiate between small and large bowel. So the way you can do that is anatomically, small bowel will be more likely to be centered in the middle, and large bowel would be in the periphery. And also in terms of size, there's differences. So small bowel, the upper limit is 3 centimeters. In large bowel, 6 centimeters, and the cecum is 9 centimeters. So it's the rule of 3, 6, 9. There's also other differences between small and large bowel, such as, I don't know if you can see my mouse, but in small bowel, you have these valvular convergentes, which transverse across the entire width of the small bowel, which large bowel doesn't have. It has haustra instead. And also large bowel may contain feces and small bowel won't. So once you've looked at the bowel, you can look at the dense structures. So that would be your bones and calcifications if there are any. On an abdominal x-ray, the bones you can see are the ribs, the lumbar vertebrae, the sacrum and the iliac bones, and the head of the femur. And so it's quite useful to just do a quick scan of those to check for any fractures or anything like that. Next, you move on to O, so organs and soft tissue. In an abdominal x-ray, you can sometimes see the liver edge. You can see the kind of kidneys, the inferior pole of the kidney can be seen in this x-ray, and you can see the psoas muscles, which go on either side of the lumbar vertebrae. And these can be quite useful just to kind of get your bearings, because for instance, if you have calcifications just below the liver edge, that would suggest something like gallstones, because that's where the gallbladder would be located. Whereas if you see calcifications in the region where you'd expect to see the kidney, that would be more suggestive of renal stones. And then finally, you have a look for external objects. In this abdominal x-ray, there's an artifact which potentially is a button of their trousers or something. So now I've got a few examples of abdominal x-rays. So if you don't mind just putting down what you think the answer is in the chat or unmuting yourself. Just working through A, B, D, O, X. What's the abnormality in this abdominal x-ray? Anyone? Close, good try. So if we follow the ABDOX approach, you can see that looking at air's black on an X-ray. This is the liver, right? You can see black above the liver, which is suggestive of a pneumoperitoneum, which you can also see in a chest X-ray, and that's suggestive of bowel perforation. In terms of in the actual bowels, they do look a little bit abnormal. However, the main abnormality in the bowel is this thing called Wriggler's sign. This is a double wall sign and actually is quite difficult to tell, but is basically suggestive of air being both inside the bowel and outside the bowel. And so coupled with the pneumoperitoneum, it's suggestive of bowel perforation. To be honest, I think a chest X-ray is better when you're suspecting bowel perforation, because seeing a pneumoperitoneum is easier to identify than Wriggler's sign, but it's just a sign that might be useful for you to just to be aware of. Does anyone know the abnormality in this abdominal X-ray? Someone's already said it for the previous one. Yeah, perfect, thank you. Small bowel obstruction. So there doesn't appear to be air anywhere that you wouldn't expect it to be. In terms of the bowel, this is small bowel. You can tell because it has the valvular coniventes, these lines transversing across the entire width of the small bowel. And it also appears a little bit dilated, and it has a kind of coiled spring appearance is what it's called. And this is very suggestive of small bowel obstruction. Okay, does anyone know what the abnormality is on the abdominal X-ray on the left? If you don't, it's fine. I don't know how much you've done with abdominal X-rays. Perfect, so it's volvulus. Both pictures are volvuluses, volvuli, don't know the plural. The one on the left is got a coffee bean appearance, which is classic of a sigmoid volvulus. So it's a sigmoid portion of the intestine, which is kind of twisted on itself and its mesentery, causing large bowel obstruction. The one on the right is a cecal volvulus, and this is when the cecum portion has twisted on itself. This is also, I think it can be called the fetal sign. I didn't really think it looks like one, so I didn't put a little icon of one. This you can tell is a cecal volvulus because you have a gap. It's no bowel present in the left iliac fossa, which is where the cecum would be expected to be found. And these are causes of large bowel obstruction. So in terms of causes of small and large bowel obstruction, we've obviously spoken about volvuli being one cause of large bowel obstruction and can also be a cause of small bowel obstruction. Does anyone know any other causes of small bowel obstruction and large bowel obstruction? Perfect, Annavi. So adhesions. Adhesions is the most common cause of small bowel obstruction, and yeah, so tumor. So malignancy is the most common cause of large bowel obstruction. Small bowel obstruction is more common than large bowel obstruction in general. And yeah, so hernia can also cause small bowel obstruction. So adhesions and malignancy are the ones that are kind of the most common causes. You can also have hernias and volvuli causing it, and also diverticular disease too. So does anyone know what the abnormality is in this abdominal X-ray? Or can guess which kind of part of abdo X is abnormal? Okay, so working through abdo, so A, there doesn't appear to be kind of air where it's not meant to be. You can see that the bowel's slightly darker because there's air inside it. In terms of B, the large bowel appears quite dilated, if you remember the rule of 3-6-9. And also, it doesn't seem to have any of its kind of bowel markings. You can't really see the haustra. And this is quite classic of like toxic megacolon. which is basically just severe dilatation of the colon. There's many causes of it. Oh yeah, perfect. Someone said toxic megacolon. Yes, it is. There is many causes of it. For example, C. difficile infection can cause it, and also so can ulcerative colitis too. Another feature which is also often associated with ulcerative colitis that might be seen in an abdominal x-ray is this thing called thumbprinting. If you can see my mouse, I'm kind of hovering over one of the thumbprint things on the abdominal x-ray / hopefully you can see what the thumbprinting is. And this basically is suggestive of edema and kind of inflammation of the bowel wall, which makes sense that someone who does have ulcerative colitis may have this sign on their abdominal x-ray. Does anyone know the abnormality in this, or just guess which letter A, B, D, O, X is abnormal? Yeah, thank you. So you can see that there's you can't really see the bowel very well in this, but you can see calcifications around the area you would expect to see the kidneys. This is actually called the Staghorn calculus. Oh, sorry. This is called a Staghorn calculus because you can actually kind of see the anatomy of the kidney. So you can see roughly the rough outline of the renal pelvis and the calyxes and things. Renal stones would be a little bit smaller, but would look quite similar in terms of they'd be white little dots. Does anyone know what the thing on the right is? Yeah, so these are gallstones, and you can tell that because they're kind of just underneath where you'd expect the liver to be, and so you'd think that they're gallstones. And they also seem to have some kind of like clips at the top of the x-ray as well. Does anyone know what, not really abnormality, but what kind of external object is in this abdominal x-ray? Yeah, so this is a suprapubic catheter because it's not going straight down from the bladder downwards. It seems to kind of be coming out of the patient a little bit above. But yes, it's a suprapubic catheter because it's in the region where you'd expect the bladder to be. Okay, so that was my last slide on kind of the explanation side of things. I hope that was useful and it made sense. If you have any questions, please let me know. I think with abdominal x-rays and also chest x-rays, it's just really important to just say what you see and work through it systematically. And it should hopefully, at least you'll be able to describe what you think the abnormality is, even if you might not be able to say what exactly the abnormality is. Does anyone have any questions, or we can move on to the questions? Just let me know if you have any questions. I'd given you time when this lecture to do the questions. I don't know who has had chance to do them. I was going to give you a couple of seconds to just work through them now, and then we can go through them. I was thinking of giving you around like 30 seconds for each question, and then there's 10 questions, and then we can go through them after. So I hope you have like a pen and paper or somewhere where you can jot down your answers. So this is question 1. Yes, these are the same questions on the handout. Okay, this is question 2. This is question 3. Question 4. This is actually quite mean because we've not spoken about this in this lecture, but I thought I was struggling to think of questions, and hopefully will be a useful learning point. So don't worry if you don't know the answer to this. I don't think I would have known the answer to this time in 3rd year. Okay, question 5. Question 6. Question 7. Question 8. Question 9. And question 10. Okay, so I hope you found this okay. We can just go through the answers now. So question 1, it was, sorry, the photos are obscuring my view. It's a 27-year-old male presenting with a 2-week history of lethargy, myalgia, and diarrhea. He has right upper quadrant pain and a tattoo is found. So SBAs tend to be a little bit stereotypical. So he has a tattoo. He mentions he got it when he was backpacking around Asia 3 months ago. He also mentions he's had all the appropriate vaccinations before traveling. And in terms of his blood tests, you can see that when you first look at ALP and ALT, you can see that ALT is a lot, the increase is a lot higher than that seen for ALP. Then you'd next look at AST to ALT ratio. AST is not 2 times greater than ALT, and so it just suggests it's a hepatocellular injury of some kind, and so that would rule out gallstones, which would be an obstructive cause, and so would be a predominantly raised ALP and GGT picture. In terms of the history itself, you can rule out paracetamol overdose, because they probably would have mentioned that if that was the case. And because he's had a tattoo whilst backpacking around Asia, it could be suggestive of hepatitis B or hepatitis C. I was a bit mean and I said he's had all the appropriate vaccinations before traveling, and there is actually a prophylactic vaccination you can take for hepatitis B, but that doesn't exist for hepatitis C, and so the most likely diagnosis would be hepatitis C. In terms of question 2, it's 45-year-old female referred to A&E with the 3-hour history of right upper quadrant pain, which radiates to her right shoulder, as well as nausea and vomiting, and she's also jaundiced. So I don't know how much GI stuff you guys have done, but from the history, it's quite suggestive of cholecystitis, which is associated with I think it's the 4 Fs. So female, 40, fat, fertile, of which she takes the category for female and 40. And the history as well is quite suggestive, especially with the radiation to her right shoulder, because that's to do with the referred pain dermatome thing, to do with an inflamed gallbladder. So that's trying to emphasize that it's important to interpret the clinical history as well as alongside the test, because it can help you out. In terms of the liver function tests, bilirubin's raised, and looking at ALT and ALP, ALP is raised to a greater degree than ALT, and so that's suggestive of an obstructive cause of a cholestatic liver injury, which cholecystitis would fit for that. So question 3, it's a man presents to clinic with a 1-week history of abdominal pain. He has hepatomegaly on examination and liver function tests. First of all, looking at ALT and ALP. ALT is raised, ALP is not. And then you look at the AST to ALT ratio. AST is 2 times greater than ALT in this scenario because it's 101, ALT is 55. The GGT is also raised, and so this is suggestive of alcoholic liver disease causing this man's abdominal pain. Again, you can use the history to help you exclude some of the other ones as well. So sorry, this was quite mean. She's a 50-year-old woman referred to rheumatoid clinic after her ALP levels were found to be 300, so that's raised. She's also found to be serum anti-mitochondrial antibody positive. Based on this, what's the most likely diagnosis? So you could have, if you didn't know, you could have tried to guess a little bit, because she's been referred to rheumatoid clinic, which would be quite unlikely with someone with hepatitis B infection or someone with alcoholic liver disease. Rheumatoid arthritis, always forget the antibodies. I think it's like rheumatoid factor, isn't it? They would say something along those lines, or citrulinated peptide, I think the other one is, something like that. Anti-mitochondrial antibody is not associated with rheumatoid arthritis, so you could maybe exclude that one. And so you're left with primary biliary cirrhosis and primary sclerosing cholangitis. Primary biliary cirrhosis is the correct answer, and BMJ best medical practice says that for diagnosis of primary biliary cirrhosis, you can make that with a raised ALP and a anti-mitochondrial antibody positive. Primary biliary cirrhosis, for those that don't know, is basically when you have inflammation of the intrahepatic ducts. Primary sclerosing cholangitis is where you have, I think it's inflammation of both the intra and also extrahepatic ducts, and it tends to be associated in SBAs with ulcerative colitis and being P-ANCA positive. So which of the following is the best acute marker of liver function? So we spoke at the beginning about ALT and AST being kind of better markers of injury to the liver rather than function. Same for ALP. INR and albumin are both synthesized, well, the clotting factors and albumin are both synthesized by the liver. However, albumin, because of its long half-life, is a better marker of acute liver function, whereas INR is a better marker of, sorry, did I say acute? Albumin is a better marker of chronic liver function, whereas INR is a better marker for acute liver function. So what is the most common cause of small bowel obstruction? So in the table, we went through it, it's adhesions. And small bowel obstruction on the x-ray is like the coiled, tightly coiled spring appearance. So what does this abdominal x-ray show? So if you go through the A, B, D, O, there doesn't really appear to be kind of air where it shouldn't be. If you look at the bowel, the large bowel appears quite dilated. And so that would be quite suggestive of large bowel obstruction. So patient presents with ulcerative colitis, which are the following radiological signs is often associated with this condition. Sorry, I don't know if this is phrased the best, but I wanted to basically just emphasize the different signs and what they're associated with. So thumb printing was the one where it looks like there's kind of someone's taken their thumb and just put it on the abdominal x-ray, suggestive of large bowel wall thickening. And so that can be associated with ulcerative colitis. The coffee bean appearance is associated with sigmoid volvulus, the embryo sign or the fetal sign with the cecal volvulus, Wriggler's sign with bowel perforation, that was the first one we did. Frog's leg sign was my imagination. So this one is a patient presents with severe abdo pain and vomiting. They've not passed flatus since the onset of the pain. What is the cause of pain demonstrated on this abdominal x-ray? So again, you can kind of list some differentials based on what they've presented with. So they've been having vomiting and they've not passed flatus and they have abdominal pain, which in itself is kind of suggestive of some form of obstruction. And then when you look at the abdominal x-ray, you can see that the small bowel has that tightly coiled appearance look, which is suggestive of small bowel obstruction. Yeah, put another spring there. And then finally, what artifacts can be seen on this abdominal x-ray? So if you kind of went through abdo and then for O, organs and soft tissues, this is kind of going from where you'd expect the kidney to be, down the ureter and into the bladder. And so out of the options given, a uteric stent would be the most appropriate and most suggestive of this. And this can be used like if someone's, for example, had like uteric stones or something, you can put this to help. And so that was my presentation. I put some useful links which have like quizzes and testing yourself, because I think that's probably the most useful thing to do when you're trying to learn how to interpret liver function tests and abdominal x-rays.